All right, welcome everybody. It's just about 3 o'clock, so we will get started. Jared's going to go ahead and launch a poll, and he'll give you some instructions about some housekeeping with this session. Jared.
Yeah, thanks, Linda. So while the poll's coming up, a couple of things. By this point in the COVID-19 process, we're all pretty familiar with Zoom, but for those who may be less familiar, we'll give a couple of points of instruction on the best way to use this. We do hope for this to be an open discussion. If there are questions, we encourage you to ask them. So we would encourage any of you who feel so comfortable, turn on your camera, take part in the conversation. And then if you have a question to ask, be sure to turn on your microphone. Your camera and your microphone controls are found in the bottom left corner of your screen. You can also ask a question at any time using the little chat function. Middle of your screen at the bottom, there's what looks like a text message icon. You can press that and then you can ask your questions here. All right. And finally, let's see if we can get that polling to launch. This poll is to help our educators understand kind of the audience and where everybody is at as far as their education, their comfort, and their expertise in this topic. It'll help guide our conversation really for the next 3 weeks. So the poll should have appeared on your screen now. Go ahead and select for 3 questions in this particular poll your answer, and you can use the scroll bar, or you can move the polling box anywhere on your screen. We'll give that a couple of minutes, maybe.
Yeah, and actually what I'll do is I'll go ahead and introduce Dr. Beck and Jennifer Shaw. Just so everybody knows, while you're answering the poll, this is a 3-part series of caring for patients and families during end-of-life situations. This was an ask from St. John's, so I appreciate that, and I really appreciate Dr. Beck and her whole team and for coming together and putting this series on. We do have 3 dates, the 20th, 27th, and September 3rd. And sorry, I'm in the process of having to move my slides forward. There we go. So I'll go ahead and introduce Dr. Beck. Dr. Anna Beck is the Director of Supportive Oncology and Survivorship and an investigator at Huntsman Cancer Institute. She's a professor and director of the University Supportive and Palliative Care program at the University of Utah School of Medicine. Dr. Beck is also a hospice medical director at Community Nursing Services and Home Health and Hospice. Thank you so much. I'm very thrilled that we get to have Dr. Beck here. Jennifer Shaw is part of the team, and she is a nurse practitioner with the Supportive Oncology and Survivorship program at the Huntsman Cancer Institute. Her areas of interest are addressing emotional and physical distress, ethical concerns and communication, and needs at the time of diagnosis and towards the end of life. So thank you, Jennifer, for joining us. A couple other housekeeping things while we're finishing that poll. There we go. Our topic next week is the medication support for end-of-life, symptom management and discussion of comfort care order sets. And then, all right, there we go. September 3rd, we've got promoting staff resiliency and coping with difficult work situations. So we've got a great lineup. Just so you know, we do not have any disclosures that have been released, so we are good. There are no disclosures. And the very last thing is for nurse contact hours, we did get an approval for application, and those of you who are nurses, just make sure you finish the final questions at the end for the evaluation. And that should be good. Okay, Jared, are we done with the poll?
Looks like we're about done with the poll.
Great. I'm going to go ahead and show Dr. Beck. I'll get your slides up.
Okay.
Oops, I have to get the next one, but there we go.
All right. Yeah, we do have about 17 responses to the polling, so we'll go ahead and end the polling now. Dr. Beck, would you like me to announce those results?
Yeah.
Okay.
Great. Thank you, Jared.
So let's go through those. Question 1, please rate your current degree of knowledge on today's topic, Introduction to Palliative Care and Compassionate Communication with Patients and Families. So a relatively small number indicated they have an excellent subject knowledge. I suppose that's why they've come for additional education. The majority of respondents, 8 in each category, said good and fair. Nobody esteems themselves as being poor in that knowledge category. Question 2, please rate your current degree of personal confidence on today's topic. Again, the same results. We have an expert who look forward to hearing their contributions, and then we have half and half as far as the good and the fair categories. And finally, I believe this content will be relevant to my work and the patients I care for. Well, I suppose people are here because they agree that. We have 12 who strongly agree and 5 who agree. Thankfully, nobody disagreed. We appreciate your vote of confidence. And I have a high degree of confidence in these educators, this team that we've spoken with and putting together this series. They are renowned, they are well informed, and I'm excited to hear what they teach us today.
Great.
All right.
Dr. Beck, you are on.
All right. We are used to teaching a class like this in an interactive fashion, so I hope you guys don't mind either jumping on the chat or unmuting and yelling at us. That's totally fine. We welcome that. Okay. Next slide, please, Linda.
Yep.
So the objectives today, we want to make sure that you understand what end of life might look like. Many of you guys, I'm sure, have seen end of life in patients, but we want to try to present it from the caregiver's perspective. We're going to touch on what's the difference between palliative care and hospice, because this is a common question that people will ask. You may be clear on it, but patients are often unclear about it. And then lastly, we want to be able to identify at least 2 situations where a referral to palliative care might be helpful and why. Let me just start by saying that I think one of the things that we oftentimes forget is that when we're caring for a patient who's dying, they're critically ill. I mean, these are patients that would normally be in the intensive care unit. And so we may be taking care of them in the hospital, but we also may be seeing them in a hospice situation. And it's really kind of remarkable when you think about it that patients are in their homes and critically ill and being cared for by people who may never have been in this position ever before. So I think that's something that we as the experts and the coaches, and when I'm talking about we, I'm talking about everybody who's here today, that when we're taking care of patients at end of life, we really have to prepare the family members to feel like they're able to do this and that they're supported, because these are critically ill patients. They can often develop symptoms rapidly, and it's our job to help them understand what could go wrong and what are their toolkits, what's going to be in their toolkit to manage those symptoms that can come up at end of life. And most importantly, being able to communicate with the family and caregiver about what's going on. Next slide. So there's 2 roads to death. Next slide. Oh, there we go. Okay, 2 roads to death. There's the usual road, which is on the bottom left, where patients go from being relatively intact to just progressively more sleepy and withdrawn, and then ultimately become unresponsive and pass away. There's the other road to death, which requires a lot more support for the caregivers. And this is when patients can become more restless or confused, agitated with hallucinations, and all kinds of symptom management needs. We're not going to go into the symptom management piece of this today, but I do want you to be aware that this is the pathway that we really need to kind of kick in and help those caregivers and help them feel prepared. Next slide, please. Okay, so I think it's important to always try to check in with the caregiver about what their perception is of what's going on with their loved one, because they may have a completely different idea of what death or dying may look like. For example, most people oftentimes fall back on their experience of what's happened in the movies. You know, you remember John Wayne kind of giving out sage advice until he closes his eyes and kind of sags a bit. But that isn't necessarily what it would look like in real life, as I think many of us are aware. I also think it's important to make sure that caregivers feel like they have a sense of purpose. And that sense of purpose shouldn't be to keep mom or dad or their loved one from dying, but it should be to make sure that their loved one is comfortable and that their passing is peaceful. Because if they don't, they're going to walk away from the experience with a legacy of fearing death or feeling like they failed their loved one. So really helping them understand what their goals are, and interpreting what they're feeling and experiencing. Next slide, please. So early stages of death, they may, what we call going to bed, when they become bedbound, less interested in life around them. They're going to be less involved with things coming around them and less aware. Next slide. The mid stages, again, now you're going to start seeing some physiologic changes. So their mental status is going to become more and more removed. You may hear more of the death rattle and the pooled secretions. We'll talk about that later on. The oropharyngeal dysfunction, which is part of the terminal secretions. Cheyne-Stokes breathing or irregular breathing. Mandibular breathing is when the jaw does all of the moving in the face. So you see less of the chest moving and mostly just the jaw. Delirium and near-death awareness are some of the things that can happen. And then pallor of the nose is when their nose becomes more pale and the pennant of their ear becomes flaccid and lays back against their neck. These are signs of the so-called middle stages of impending death. Next slide. In late stages, now they're unresponsive. Their mandible may be cool, their breathing is very, very slow, and oftentimes there's long periods of apnea. You no longer can distinguish a pulse, or it may be thready and tachycardic. Forehead bossing is when their forehead becomes very shiny, if you will. They're usually on their back at this point. There's drooping of the nasolabial fold, which is the fold above between your nose and your mouth that starts becoming more flattened as well too. And they can have relaxation of their sphincters. They also get that hyperextension of the neck. So it almost looks like they're looking up as they get closer to death. Next slide. So patients oftentimes are going to be obviously more fatigued and weak. And for the patient, this means that they have decreased ability to care for themselves. So they are not able to do their own personal hygiene. They can't raise their head. And I think what this means for the caregiver is that when patients are unable to shift their weight in bed, they get stiffer and there's often more pain or discomfort. So the caregiver role now means they have to help with positioning and moving the patient around or assessing for pain. If any of you guys have ever had a lovely night's sleep or you just sleep so deeply that you don't move, and you wake up feeling kind of stiff and sore in the morning, think about that with patients who are nearing end of life. They really can get quite stiff if they're unable to do those shifts and stuff that help you provide blood supply to other areas. Next slide. They also have, let's see, as they're not able to move, you start getting some skin changes over bony prominences. Probably the most common areas are the coccyx and the backs of the heels. So you can see those areas starting to break down if you can't shift them off of those bony areas. You may also notice that they get flushing or mottling as you get towards end of life. For the caregiver, they need to realize that leaving the patient in one position is not necessarily the best thing for those patients, and it's a good idea to have draw sheets and turn them. And being very careful around those bony prominences so that the skin doesn't tear or rip. Next slide. Patients also very commonly lose their appetite. And I think this can be super distressing for the caregivers because most caregivers view their role as a nurturer by feeding patients. And what they don't understand is that it's normal for patients to not be hungry. This is probably a function of the ketosis that builds up. I think pointing that out to caregivers helps. I think the other part of it is asking the patient if they're hungry, if eating makes them feel better. And generally patients will say, no, I don't feel better when I eat. I actually feel worse. So that caregivers understand that forcing patients or forcing food on them doesn't really make them feel better. It's also helpful to teach caregivers other ways for nurturing their patients, like maybe watching a movie with them or working with puzzles or things like that, or even just, sitting with them and holding their hand. Next slide. You start seeing end organ dysfunction, so change in urine color, change in the pulse, tachycardia, mottling of the skin. Caregivers oftentimes will ask for fluids because patients may appear dehydrated. Their jaw starts sagging, so they do mouth breathing, their mouth gets dry. They need help understanding that IV fluids don't necessarily reverse this process, but may actually cause more complications. Next slide. And again, there is evidence that if we give patients fluids, IV fluids towards end of life, that we can actually prolong the dying process, and we don't really improve the dehydration status that they appear to be in. Okay, next slide. This is just some pictures more of the mottling and the dependent venous pooling that can happen towards end of life. The urine also can become very concentrated and dark in appearance. These are normal findings that happen at end of life. And again, caregivers have oftentimes never seen this. So it's important to point this out and say these are things that normally happen at end of life. They're not something that you need to fix or can fix. Next slide. Patients become increasingly more removed. They become less verbal, they're harder to, they won't answer questions except with 1 or 2 syllables. So teaching caregivers how to interpret what the patients are feeling. So maybe looking for things like a furrowed brow or agitation as a sign of pain will help caregivers understand what's going on. Oftentimes they'll say, does my mom or dad or loved one understand? Can they still hear me? I think it's helpful sometimes to teach them about the fact that if you touch their eyelash and they don't have that reflex of the eye twitching, that's really equivalent to full anesthesia, and they may therefore not be able to hear them anymore. It's still helpful for caregivers to be able to talk to patients, but when they're that unresponsive, when they've lost their eyelash reflex, they're probably very deep. Next slide. And again, we talked a little bit about how they're less likely to be able to communicate. Caregivers should be aware that patients may not be able to respond to them, but they still may be able to hear. And this is a time to really kind of diminish the amount of sensory overload that the patient might be experiencing. There's also this key piece about letting the patient know that it's okay to let go, that people are going to miss them and love them, but it's okay if they let go. Next slide. So communicating with dying, again, being sensitive. This isn't the time to have everybody in the room. The more noise, oftentimes the more agitated that can make the loved one. Their skin may be more sensitive, so holding their hand as opposed to stroking it is probably more comforting. Oftentimes it's the quiet presence of a loved one and a 1 or 2 loved ones rather than a room full of people watching on. Next slide. And then terminal delirium often is present, and it's moaning and groaning, agitation. And again, these are times when it's super important to support the caregivers, because we don't want them left with the impression that their patient, or their loved one rather, was agitated. This is the time when we want to make sure that we're medicating them and supporting them a lot. And we'll talk more about that kind of management with later slides or later talks. Next slide. It's important also to educate caregivers about the fact that using morphine or any other opioids or benzodiazepines for symptom management at end of life doesn't hasten death. As long as they're using them for symptoms, there's no role for increasing opioids or benzodiazepines in the absence of symptoms, though. Next slide. At the end, patients do lose the ability to suck or swallow, and so there's that buildup of secretions in the throat and in the pharynx and trachea, the so-called terminal secretions or death rattle. This is something that can happen at end of life. Again, we don't recommend suctioning because that tends to cause a lot of distress. It's more important to work on positioning the patient so that maybe they're on their side with the head of the bed elevated. Next slide. They also can lose the ability to close their eyes because of loss of the retroorbital fat pad. So again, a good role for the caregiver is to put moisturizing drops there in the eyes so that they stay moist. Next slide are just signs that death has occurred. And again, most of these go without speaking. The urine and stool may be released, and I don't know that people are often aware that just the relaxive sphincter muscles can happen, so they may become incontinent of stool or bladder at end of life. And again, just normalization of that reflex is helpful for caregivers. Next slide. Having a plan for your family is helpful so that when death happens, they know who to call. They know that it's okay to spend time with the body, to still touch them and kiss them. All of that is part of the grieving process and part of closure. And our job is to try to clean up any catheters or things that we've introduced at end of life so that the patient looks as normal as possible. Next slide.
So I'm going to jump in here now. And one of the things we'd hope to do is to help you understand a little bit about how palliative care works in our institution. And since it's a whole lot more than dying, we're going to kind of switch gears for a minute and get broader. One way we think about palliative care is that we want to give patients a voice and help them keep hope alive. Both Anna and I thought about a patient we had seen in the past week or two, and we want to kind of walk you through their care as a way to illustrate this. So next slide. This was a young man who spent almost a month in the hospital, and part of our care is hospital-based and part of our care is clinic-based. He had been diagnosed with sarcoma in his face this February and very rapidly was sent from Wyoming to Salt Lake City for treatment, where he's been living with extended family. So he went through a whole lot of chemotherapy, a whole lot of radiation. His tumor responded beautifully, but in the interest of optimizing his curative chances, they decided to keep going. He has not seen his family since diagnosis, and he was hospitalized with severe mucositis. When we were consulted, the staff was concerned that he was just not participating in his care at all, had stopped eating, and had lost 30 pounds in approximately 3 weeks. So the role of palliative care in this patient is very different than the role of the dying patient. Next slide. What we do is we try to recognize and minimize suffering. And with this gentleman, we're talking about physical distress from mucositis. There's a little picture there. He had some of the worst mucositis I'd ever seen, which was kind of the chemo and the radiation perfect storm. So he couldn't open his mouth, he couldn't speak, he couldn't swallow. We put him on a PCA and tried everything we could in terms of mouth swishes and swashes to get him through that period of time. It took much longer than normal to resolve. He also had emotional distress, and it was kind of like a teenage thing. He just was a passive participant in his care. He had learned to just lie there on the bed and people would do things to him, and he became more and more and more withdrawn. Turns out he did have a history of depression and had been through a lot personally and in terms of his family life. In addition to that, we started recognizing spiritual distress. He had lost his family's faith in God as a teenager and felt that because of that, he was being punished with this illness. And God was testing him. And to punish him for his disbelief and to help him recognize how powerful God really was. So there's a significant role for us here, and none of this really had to do with active dying. The other role we play is to discuss his goals, and we'll talk about that later. So next slide.
So I'm going to present a little different case, just at the other end of the hospice and palliative care spectrum. And this is a 76-year-old woman who I saw as an outpatient. She had metastatic colon cancer. She'd already been heavily pretreated with chemotherapy and surgery, all in the attempts of trying to palliate her disease. And she presented with her family. She had a very loving, supportive family. And they were very concerned because they felt like she was declining and wasn't being as engaged in therapy as they were hoping she would be. When asked about her goals and just getting to know her, she verbalized that she loves to garden. Spending time with her grandchildren was the thing that rocked her life. And when we talked about how her treatment had affected her. She had this peripheral neuropathy, which made walking difficult and made working in her garden difficult. She had fatigue, which also made working in the garden difficult. She'd also lost 20% of her body weight in the last 3 months. So she was really feeling like she was, not really meeting the needs of her family, who were encouraging her to continue with treatment and continue to do whatever she could to be a part of their lives. Next slide. So just to give you a sense for where she was with her disease, this is an image of her liver and you can see that she has extensive replacement of her liver with metastatic colon cancer. So this is not somebody like Jennifer's case where we're working for a curative sense. This is somebody who's really struggling with, at least one organ dysfunction, but with her weight loss and her peripheral neuropathy, she's really approaching on multi-organ system failure. Next slide. So one of the questions we often get asked is, how do I pitch palliative care to my patients or my providers without making it sound like these patients are like they're going to lose hope? So, we could talk about that, but this video is just a really cute way of talking about how to introduce palliative care to both patients as well as providers. So let's just take a look at the video.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
How do you distinguish palliative care from hospice? Well, hospice is really kind of a subset of palliative care. Palliative care can begin at the onset or the diagnosis. So it can start from the very diagnosis of any kind of a serious illness, whether it's a terminal one, incurable one or not. And it can happen in any setting, in the outpatient setting or an inpatient setting. Hospice, on the other hand, next button there, Linda, is really for patients at end of life who are no longer interested in pursuing anti-cancer or any type of treatment for their terminal illness. So it really focuses on symptom management and comfort care within the patient's current care environment. There's always something. So palliative care and then hospice is a subset of palliative care, and it's part of it. Next slide, please.
Oops. Sorry, this is the hard part. There we go.
Okay, so I'm going to chime in and just talk a little bit about when do you introduce palliative care. And we have a rule of thumb which says at diagnosis of anything that's a serious illness and potentially contributing to the end of your life. But also whenever there's physical or emotional or spiritual distress is a good time to think about palliative care. Whenever there's a need for an additional layer of support. And And that's what we like to think, is that if someone's diagnosed with a serious illness, curative care may take 90% of the energy of all the medical providers. But if there are any unmanaged symptoms, then palliative care can do 10% of the care. They live for a year, they live for 2 years. Now it's nearing the end of life, and suddenly those percentages have switched, and curative care is only, or disease-directed therapy is only 10% of what we're trying to do, and 90% of what we're trying to do is optimize comfort and minimize suffering. So that's not really how it works all the time. And if we can get this video to work, this is actually when palliative care is often asked to show up and help people when they're dying. So this resonates with me. I'm ready.
Hi. We got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
So that sometimes happens to us, where someone has, a day or two left to live, and we're being asked to talk about dying but not mention the word. And it'd be so nice to be able to move palliative care a little upstream of there. So that's our goal. We thought we'd talk a little bit back to our cases and how we talk about goals, and focus for a minute on communication issues. I'll go back to my 20-year-old guy. When we were able to establish a relationship with him and say, now listen, we want to really hear what this is like for you, and what are you going through this treatment for? And his first statement, and he was very teary, was, I need a break. I can't do this anymore. And he hadn't told anybody that. So as a palliative care team, we can actually, look at the care plan and say, okay, can we hold radiation for a week, 10 days, give him a chance to recover? And we were able to do that. His second goal was, I need to go home. He's 20. He hasn't been home in months. He's scared. He's been living with a cousin. And so we really could say, well, wait a minute, can we marshal our resources and do some of his care in Wyoming instead of asking him to live here? So his overall goal was, I'm determined to finish treatment. He was very frightened that he was going to lose his eye, and there was a significant possibility of that. But he said, I'd rather lose my eye than my life. And being able to talk about this, I think, gave him some power over what was happening. And we could say, we share the same hopes you have, and we're going to work to make this as easy as possible. So talking about goals is a really important part of palliative care. And that's kind of how it unfolded with my guy. Do we have another slide? Anna, I think this is yours.
Yeah, so with my patient now, they're at a different place in their life. And now remember, she's in the clinic with some of her family members. And really, there's a sense of conflict here, because the family is wanting her to be made better so that she can continue the fight. But when you ask her, no, they understood that this was not a curable disease. And so when you say to her, knowing that your time may be short, what matters the most for you now? Her answer is, being able to spend time with my family, being able to spend time with my children. I'd like to at least go out and be able to spend some time in my garden. Even if I can't get down and garden, that's where I want to be. So next point then. The next question is, do you feel like your treatments are helping you achieve those goals? Her answer was a clear no. You know, I'm down here at Huntsman every week. When I get my treatments, my neuropathy is worse. I'm more tired. I'm not hungry. I can't do the things that I used to be able to do. And I'm worried that if I keep going on these treatments, that, you know, there's just no end in sight. Having that safe space where she's able to verbalize those things, and we're acting as the coach to allow that safe space to develop. And then having her family members hear those words from her helped them understand that maybe continuing on with treatments that weren't helping her achieve the things that were important to her was maybe not the right thing to do. So it really helped kind of diffuse some of the conflict by just allowing the patient to have a voice and talk about the things that are most important, rather than getting caught up in, I don't want to disappoint my family, and I don't want to disappoint my doctor. It became more about, well, you're clearly doing this for a reason. What is the reason? And that is to be at home, to be with my family. Next slide, please. So let's kind of point out a few little communication pearls, and then we're going to play a video of one of these, how some of these communication scenarios can kind of play out. But one of the things that I want you to think about is that you're really the expert in these conversations. When you're talking to patients and family members about about what's important to them, these are conversations they've likely never had with their family. So you're the one that should be able to help tease out those important points that the patient can verbalize and that the family can hear it. So think of yourself as the expert and the coach when it comes to these kinds of conversations, the facilitator. You're not the judge. You don't tell them whether or not that's an important goal or not, but you're the one that helps tease it out and make sure that it's heard by everybody nearby.
Okay, I'm going to chime in and just add a few of my communication thoughts. One is that few of us were born being comfortable talking about bad outcomes or treatment not working or death being near. And some of the things that have helped me to remember over time is that patients have goals that are more than just living longer. And it's our job to, as Anna says, kind of tease that out. The other is you're not going to harm patients or families by talking about their fears, their worries. In fact, it can be very therapeutic and help build relationships. One thing to be aware of is that patients are ambivalent about information. Almost everyone, if you say, hey, how much do you want to know about your illness? They'll say, well, I want to be fully informed. But beneath that request is some ambivalence about what you'd want to know if the news were not good. One of the key barriers to talking with patients and families in an honest way is our own anxiety. And I love this sort of study which divided providers into those who are temperamentally avoiders, optimists, and realists. And we divide about equally in these categories. And each one, if you have a communication style or a personal preference, you might sort of say, where do you land in these categories? Each one has benefits and each one has drawbacks. So there are definitely providers who avoid these discussions. And these are people who say, well, we don't know how long people have to live. If I tell them that, I might misdirect them, and I'd rather just, see what happens. We'll keep doing what we're doing. We'll take it week by week. And the drawback, if you're an avoider, is that you appear kind of aloof to families and somehow unwilling to share your expertise. And sometimes people will end up distrusting you. I've had patients say, well, I don't think they're telling me the truth. They're hiding something. So then there are those of us who are optimists, and we're all about hope. We want this patient and this family to maintain hope, no matter what. And it's comfortable for providers to do that. It's reassuring for families. The drawback is patients and families are really unprepared if things don't work out as planned. Then there are those of us who are realists, and we're sort of the folks who say it's important the patients know what's going on and that their families are prepared for the fact that this could work out the way we want it to, but there might be a setback. And our problem is that we can sound kind of gruff, matter of fact, about a situation which is really quite sensitive. So coping with your own anxiety is kind of a good first step. I don't think any of us get better at doing this without practicing, and you're about to see me practice. So one of the challenges is how do you keep hope alive? Even in a situation which is scary, even in a situation where death is nearing, or when things feel like they're no longer under control. And my answer to that question, and maybe Anna feels could elaborate, is I just do that by being curious. And we can ask questions like, what gives you hope? What are you fighting for? Help me understand what you most want to have happen in the next month. Give them a time frame. And that can really help go from just talking about bad news to talking about what gives you strength, what gives you hope, and how can we maximize that. So I don't know if you would want to add anything, Anna, or not, but
I think one of my key questions that I'll ask is, what makes your life worth living? Because I think that really helps people define that line in the sand in terms of what they want to be able to try to protect and keep going with for as long as possible. And I think it's important for families to hear what makes their life worth living. And I think it's important for the entire clinical team to know that as well, too.
Yeah. So this is a very painful process for some of us, but we recorded ourselves acting out a conversation with the patient, and in a situation where we're trying to articulate goals, and we thought we'd play it and then ask you guys for feedback and questions and go from there. So I think this is it.
Okay. Jennifer's part's a little bit soft, so we just have to make sure that we can hear the recording. So it is there though.
Mrs. Beck, I understand you brought your husband into the emergency room today with some respiratory symptoms. He's been diagnosed as positive with COVID, and you were hoping to talk to someone about what this means.
Yeah, the doctor said something about whether or not he would want to be on the breathing machine, and he and I haven't really talked about that, but why would I not want him on the breathing machine? I want him to survive this. I just don't understand why he asked that question.
Yeah, that's a pretty overwhelming thing to be asked.
Yeah.
Tell me a little bit about your dad and what kind of person he is.
Well, he's a real active guy. He's an outdoors guy. He loves to fish and hunt, and we have a couple of dogs. He likes to train the dogs. He doesn't know how to load the dishwasher.
Okay.
But yeah, he's a pretty vigorous guy. You wouldn't know it. He's 80 years old, and I think he looks younger than 80. A lot of people don't realize that he's 80 because he's so active all the time. That's
okay.
That's where he loves to be, is outdoors hunting.
Okay. Well, one way to start thinking about some of these decisions is to look at what makes his life meaningful and what a life worth living would look like for him. It sounds like being outside and being active and being vital is an important part of who he is.
Oh, no question. Yeah, he loves to tell stories. Oh my God, and his stories go on and on and on. So yeah,
okay.
That's who he is.
So he's a strong man, and you imagine him being willing to go through a lot in order to continue that kind of a life that he's used to living.
Yes, absolutely.
Yeah. Okay. And you haven't really talked much about what he'd be willing to go through if he were critically ill.
No, not really.
Or, one scenario is sometimes when people their lungs aren't working and they need a breathing machine, that means that they would either if they recovered, they might end up being in a care center for a period of time. Is that something you imagine him wanting to do?
No, no, he would not want that. No.
Okay. I'm thinking, is there a quality of life that he would not find meaningful? Being in a care center would be hard for him.
Yeah.
Anything else that you think he would have difficulty if that were what his life looked like?
I think he wouldn't like it if he was like confused and wouldn't be able to tell us his stories, and because he loves doing that. He loves sitting around at the dinner table and telling his stories over and over and over. That's something that he enjoys a lot. He loves to tell hunting stories.
Yeah. So being awake and able to participate in family life and telling you things is really important.
Yeah. Yeah.
Okay. Is it all right if I just, based on what you've told me, made a recommendation and maybe some guidance as we move forward?
Yeah, please.
Okay. Our team here is going to do everything we know how to do to help your father recover from this infection.
Good.
If he becomes sicker or he takes a turn for the worse, and we're worried that he may not recover, or if he did live, he would not be able to be awake or communicate or take care of himself, then we would need to revisit whether or not he would want life support at that time.
How
does that sound to you?
Yeah, that sounds more like, I think he would agree to that. I think he would definitely agree to that. I mean, I don't want to lose my dad, but I also know that he has really strong opinions about what he wants. And I think that would fit better with what he wants.
Okay, okay. Well, we'll have ongoing discussions. And if there are other people in your family who love him and have opinions about what he might want or not want, we'll include them in the discussion as well.
Okay, yeah, that's good.
Sound okay to you?
Yeah.
Okay, I'm sorry this is happening.
Yeah, me too. But he's a fighter. I bet he gets through this.
Okay.
Okay, so let me just back up a slide still, Linda. So I'm going to ask you guys to maybe unmute and make Jennifer and I feel good, but what went well in that conversation? What did you guys see that you thought worked in terms of keeping hope alive for somebody who's potentially facing end of life?
Hi, this is Patricia Galbraith from the social work department. I just wanted to say it was really nice in that video to see the transition that the daughter made when she was saying, I want to keep my dad alive, I want everything happening. And then it was able to be pointed out, okay, if he's on a breathing machine, he would be in a care facility. What are your thoughts about that? And you could see there was just a quick change about how she thought about decisions and what he would really want. I think that was a meaningful highlight in the video. Thank you.
Thanks, Patricia. And again, I'm going to point out, I think that what Jennifer was doing there was she was acting as the coach, right? She's the expert in this conversation because the daughter's never been in this position before. Dad's always been robust and vital, and now all of a sudden he's not. And they've likely not had these conversations. So having that coach and expert to create the safe place is what we really needed. Who else? Does anybody else see anything that you thought went well in that video?
Clear. This is Linda Sossenheimer. I thought it was really clear that Jennifer was listening. And it's really easy, I think, when we're in an anxious state of how to interact with family members that we stop and slow down and listen. And it was clear that she was just taking that time.
Yeah, I think Jennifer is really good at pacing her conversations. Especially if you're in the ER type of situation, sometimes you want to really kind of get there fast. But Jennifer really is super good about pacing things, pacing out the information, and allowing other patients or caregivers to weigh in and ask questions and give responses so that they feel like they're part of the conversation and not just being lectured to. They're involved. Yeah, great, Linda. Thank you for that. Anybody
Nancy
else?
McCluskey, Associate Professor over at the College of Nursing. I do the LNIC and Death and Dying course. Yes, I think you gave information in small amounts, which is really important, that it's not overwhelming to that individual, and kind of did a stair step. We'll do what we're going to do right now, and then if things change, then we're looking at something else, then rather giving the whole picture. So I thought it was very well done.
Thank you. Thank you for that. Great comments as well too, and observations. Anybody else? Did you notice how Jennifer really teased out what made Dad's life worth living and then built the argument on that?
Mm-hmm.
So it wasn't about what CPR would look like or necessarily having a tube down your throat. There was no sense of bullying, right? It was really built on understanding what made Dad's life worth living. And by capturing that, you're really capturing the hope, right? So that's where I think we can all feel so much better about these conversations if we start with that inquiry, that curiosity that Jennifer was mentioning earlier. If we start with that and then build off of that, the rest of the conversation will flow and will feel natural and unforced. Anybody else? And otherwise we'll move on to our last slide. So this is another interactive one.
Well, this one I didn't have. I didn't put the other section in. Were we going to show the other?
That's because we were going to just kind of take this. We wanted this to be interactive, but can anybody, maybe we can get 2 or 3 folks to just talk about something that they learned from today that they're going to take home and try to use in their practice. So just on reflecting on what you've learned today, is there something you want to use in your practice that you want to practice and make part of your own lexicon?
This is where we have to not be shy. One thing I think that you could talk about, both Dr. Beck and Jennifer, are from a small community hospital perspective with nurses, and maybe the nurses don't have any social workers around. Maybe somebody comes in suddenly and it's just kind of this trauma, and taking that same perspective, what does that conversation look like, and how, because a lot of people will say, well, we don't have a palliative care team or a hospice team or a reactive team. What are some pointers that you could give out for nursing staff in small hospitals that just kind of need that same thing, going back to I'm the expert, what you outlined?
I think I would just say what I've said already, and then having that curiosity about what's important for the patient. I don't know that you need to have a degree behind your name. You just need to be able to be practicing and willing to have these conversations in the safe space that you create with them. Jennifer, would you have anything to add on that?
Yeah, I guess what I would say is anticipate and respond to emotion before you provide information. And recognize that in a time of crisis, people aren't able to assimilate very much. So, if you can say, this is what I want this family to know. Your loved ones had a brain injury. We're worried they might recover. You don't get any, don't add any more than that. So that would be my question, is expect emotion and respond to it in a supportive way. And then realize that the information is going to come later.
Maybe we can get people to just drop it in the chat box. Just one point that you want to take into your practice. Thank you, Adria. You said, I appreciated how you look at the patient and what makes that life meaningful. It took the stress away. from talking just about their code status. Yeah, great observation, Adria. But yeah, if anybody could just drop it into the chat box, one thing that you're going to take away from the lecture today.
We've got one from Patricia that says representing the patient's voice and wishes. That's a great point.
Yep.
Anybody else? You know, while we're thinking of that, we're going to go ahead and launch the last poll, and then we hope that'll just be on your screen. You can answer it if you need to go. It's just about 4 o'clock. But please keep putting anything at the tip of our fingers. So we'll go ahead and launch that last poll. And here. And again, once you answer these polls, then you can minimize it or put it on the side. Caroline has said, I appreciate how it is viewed, as an ongoing conversation to be revisited as things change. Another one was, as a nurse, taking on more leadership with communicating with family regarding what to expect in the dying process was her take home. That's Mary. Thank you, Mary. Rochelle says, talking to patients and family sooner rather than later is going to take home as a take home for her.
Those are awesome. Thank you, guys.
Excellent. So just make sure for your nurse contact hours that you go ahead and complete the poll, and would love to hear anything else from any of you. We do have 2 more sessions. I'm very excited about them, and I know that part of the we have 2 more people from the palliative care who will be speaking next time on August 27th. We will make sure that we just get any information or questions that you may have in the aftermath. We can get those to both Dr. Beck and Jennifer. And Dr. Beck and both of you, I really, really appreciate you taking time out of your busy schedules to share your knowledge and expertise with us. It was a great presentation and really great. And I think the videos turned out wonderful.
Yeah. Thanks, everyone. It's always a challenge with Zoom, but I guess we're all going to get more and more practice with this. So thank you very much. Thank you for your comments, and thank you for being willing to interact with us.
Yep. So thank you. It's an important training session. Thank you so much. And please make sure that we get some feedback from some of you on the poll. We've got about 15 people who have responded. That's great. Some people don't like to respond because you don't need it for your contact hours, but it's great feedback for our team and for Dr. Beck's team as well to get an assessment on the education process that's going out there. So thank you for completing that poll. Any other questions, just let us know. And we will make sure we see you all on August 27th at 3 o'clock, same place, same time. Some new faces and some old faces. So thank you very much. Okay, we'll see you next time. Thank you, Dr. Beck and everybody.
Thank you, Linda. Thank you, Jared.
Take care. Bye-bye.